Dr. Robert Kushner. I'm a professor in the departments of medicine and medical education at Northwestern University Feinberg School of Medicine in Chicago. Holly?
I'm Holly Lofton. I direct the Medical Weight Management Program at NYU Langone Health in Manhattan. And I'm a clinical associate professor of surgery and medicine in the NYU Grossman School of Medicine.
Great. Scott?
Hi, I'm Scott Isaacs. I'm an endocrinologist in Atlanta at Atlanta Endocrine Associates, and I'm on the faculty at Emory University School of Medicine in the Department of Endocrinology.
Holly and Scott, I'm going to start our discussion off and talk about the consequences of obesity underdiagnosis. There's a lot of reasons for that, and I think we'll unpack that shortly, whether it's lack of education, familiarity, not wanting to talk about this subject and so forth. But the end result is that when we have a patient that comes in who has obesity and has one of multiple medical problems, we are really doing, I think, a disservice in not diagnosing obesity up front, because it seems to be a hallmark and a risk factor of so many medical problems. Do you see the same thing, Holly?
I do. And I really think it's important for us to let the patient know that if we treat their obesity, we're treating them as a whole person and not just the individual comorbidities.
We always talk about how cancer and heart disease are the two leading causes of death in the United States, globally probably as well. And interestingly, obesity is a major factor in those conditions. And diabetes, in addition, is something that really jumps out. Well, we put together on this slide in the blue the increasing prevalence of diabetes in this country over the past 20 years. And it's gone from a little less than 10% up to over 14%. Now, what we've matched this data with in orange is what percent of individuals with diabetes also have obesity. And now you're getting into the 80, 85%. If you add overweight to that, you're probably at 95% or more. Thinking of this whole idea of a diabesity, this combined epidemic. So treating a patient with diabetes and not paying attention to underlying obesity, you're missing a major factor, not only in the causation of diabetes, but also in the treatment itself. Scott, do you see that as an endocrinologist as well?
Yes, it's, we see a lot of obesity and diabetes coexisting. And a lot of times, if you see someone with obesity, it's just a matter of time before they develop diabetes.
Yeah, they kind of go hand in hand. It's unusual, at least in the United States, that you see someone with type 2 diabetes that also does not have an elevation in excess body fat, which is what we talk about obesity. So we talked about the underdiagnosis of obesity, and we know also that treating the obesity makes a big difference. And what it shows on the left is the medical problems that an individual with obesity may present with, ranging from diabetes to fatty liver disease to sleep apnea, all the way to GERD. And in the middle, what we are now identifying is how much weight loss is needed to improve that particular complication. We used to think lose weight and everything improves. Well, I think that's kind of true, but we fine-tune that now, such as if you have someone with sleep apnea, the data shows you need a little bit more weight loss than just 2 to 3% to really have an effect on sleep apnea, particularly severe sleep apnea. And that's in contrast to someone who has elevated blood pressure or dysglycemia, where you need very little weight loss to achieve a benefit. It really kind of speaks to this whole idea of treat the target, which to me is absolutely intriguing, right? With diabetes and with hyperlipidemia, we always treat the target. With obesity, we just said lose weight. And I think we're getting to a point where knowing what the condition or the complication is, we can then use that information, have a conversation with the patient about, since you have sleep apnea or you have fatty liver disease, we need to think about being more aggressive with weight loss than just a little bit of losing weight early on with lifestyle alone. So I think it gives us a window to how aggressive we want to be in thinking about what treatment of complications we want to be thinking about using. I want to turn to making a diagnosis. I'm going to invite Holly and Scott, both of you, to engage in some thought about this. And this has been such a hot topic in social media. I teach the medical school at Northwestern. I've had more pushback and conversations with the medical students about why are we using body mass index which is an anthropometric measurement, to diagnose a disease? Are you fat shaming people? Is this the right thing to do? And they're right to bring up that topic, but I think it's worth unpacking a little bit about the history of BMI and what can we do to move beyond that. Holly, let me turn to you. What are the pros and cons of using BMI? Should we throw it out, or does it still have utility?
Well, very interesting question, Bob, because we see the BMI automatically calculated in so many facets of life. We see this in our electronic medical record because it's very easy to know someone's weight and height and get this convenient number. Patients can do this themselves on their phone. Many of their scales will tell them their BMI. So it's easy information to attain, put into this equation, and determine where you fit in the spectrum of weight classes. Now, some of the cons might be it does not necessarily correlate with risk of weight-related conditions. So we've looked at some data from NHANES, which is a large longitudinal database of people over time determining what happens with their weight, their height, and then their disease risk or mortality. And we found that unless you're at extremes of BMI, the underweight or the very high in the severe obesity class, you don't have a trend that correlates BMI, height-weight ratio, with risk of disease and death. So that can be one of the cons. And of course, we have the variations of fat percentage with ethnicity, race, and other things that can change it, such as muscularity. So these are some of the limitations of using BMI solely to diagnose weight conditions.
Holly, you just brought up a point. I have so many patients that they're doing well. They lost 8% of their body weight. Everything's improving. And then they'll say, yeah, but my BMI is still in the obesity range. I've got to get it under the obesity range. And it's really such a disservice, I think, of we've had to lay this BMI idea onto patients to get so caught up in it. We really need to move beyond that. So Scott, let me ask you, where are we? What else can we do in a clinical setting, at least, to understand or identify the patient who's really at risk beyond just BMI?
Well, these are all really good points. And I do want to comment that the BMI is convenient at times, and it's a starting place, but it's certainly not the end all and be all. So what else can we do? Waist circumference gives us a very practical measurement of abdominal adiposity, of central obesity. And that's what's really important when it comes to assessing risk for cardiometabolic disease.
Agree completely, Scott. If we look at the BMI waist circumference tables, they're actually developed over 25 years ago from the NIH. They've incorporated both BMI and waist circumference, and it highlights two important points. One is we use BMI, which with all of its pitfalls still has, I think, an opportunity to identify as a screening tool in individuals at higher risk. But what it does not do is give us anything about body composition, muscle mass, where the weight or the excess fat is located. And what Scott had just talked about is where the body fat is located, particularly waist circumference, adds another value of understanding the risk of the individual. So in this particular table, you would identify the class of obesity, and based on where the weight is, it would either increase or decrease that risk. So as an example of a patient, let's say who weighs 234 pounds, is 5'10", waist circumference is 45 inches, which is elevated for a man. Anything over 40 inches for a man would be elevated risk. For a woman to be 35 inches, at least for a Caucasian woman. So if you take this particular patient, it would be someone with class 1 obesity because the BMI is 34, but because the waist circumference is elevated, it bumps up the potential risk of having complications from high to very high. So that's how you would use that. Another thing to note, though, is that all of the classification guidelines do not recommend measuring a waist circumference when the BMI is over 35. You can if you want, but if you notice, it really doesn't increase the risk any higher. And that's because the heavier you are, at least among Caucasians, the heavier you are, the waist really is already enlarged, and it doesn't increase the risk whatsoever. Interestingly, though, Holly, let me ask you this. In our own system, and when I'm with medical students or residents and I ask them to raise their hand, how many of you actually measure a waist circumference in your clinic? I'll bet you one or two hands go up at most. And if you do it with clinicians in practice, I think it's exactly the same. Is that the same in your institution? If so, why do you think that is?
I have definitely noticed that we don't really see waist circumference as one of the vital signs. We think of blood pressure, heart rate, weight, these things that we need to treat. And it's a misnomer that we're treating BMI. We're really treating fat accumulation because that is the disease that overweight and obesity is defining. So if we have a patient with a normal BMI but a high waist circumference, they're at high risk of cardiac disease, things like this. So we should really want to not only treat BMI or weight, but also deposition of fat. And it's a really easy to measure, but often forgotten vital sign.
Yeah. Scott, what do you think about that? Do you see waist circumference measured in your area?
Well, I think it's measured some of the time, but not enough. And it's just like a lot of the things that we see, these patients are very complex with diabetes, hypertension, dyslipidemia, and a number of other things. And so there's only so much time. And so we have to figure out ways to work that in. And the way that I do it is I have the medical assistant do it. We make it part of the required vital signs that the medical assistant takes.
Yeah, that is a great way of problem solving and actually getting it done. I find it is one of the easiest measurements to do. You get a height, weight, and a waist circumference. However, can be cumbersome or embarrassing if you don't do it correctly. Because if you're standing in front of the individual and you're trying to put the tape measure around them, it can be very embarrassing and offsetting to the patient. So there are several ways to do it. You can have the patient hold the tape at the iliac crest and have the patient turn around 360 degrees. Key thing is to have it horizontal, either at the iliac crest. Sometimes people do it at the umbilicus or halfway between the ribs in the iliac crest. As long as it's done routinely and reproduced the same way, that's the most important thing. It's probably one of the most useful, I think, clinical easy measurements we could do with a patient with a BMI under 35. And I'm on a quest to get people to do it, although I haven't been particularly successful just yet.
Bob, I also have my medical assistants do the vital signs, including the waist circumference at the initial visit and about every 3 months, because while we do see changes in weight, frequently if we see them monthly, the waist circumference takes a bit longer to change. And the patient is feeling different, hopefully losing weight every quarter or so. So checking those waist measurements, they see I'm really losing fat. And that's really pleasing to the patient. So what I have the medical assistants do is, just as they're carrying their stethoscope, they carry a tape measure that we want to have at least 50 to 60 inches because we have patients of all size. Of course, we don't want to stigmatize patients. They've been stigmatized in so many settings when they have obesity as a diagnosis. The last thing you want is for someone to say your tape measure is too short. So you want a nice long tape measure, and then gently place it around the patient, give the number to the person who's putting the vitals in, and then move about the day. And then if the patient asks, well, how is that? Or I get a lot of questions of, well, that's not where I wear my pants. We just explain that this is where the medical waist is, and we're measuring around the top of the iliac crest so that we have consistent measurements at different clinics or different times and different users. So let's talk a little bit about having a conversation with your patient about their weight, how we have those conversations in our practices, and how we might be able to help our listeners feel more comfortable having this conversation, because it can be cumbersome and hard to approach this subject. So we have a case here, a patient I actually saw in clinic. Her initials are MS, and she is healthy by medical standards. She takes no medication. You can see her vital signs here. She's about 5'2", weighs almost 200 pounds, and we measured her waist circumference. It's 41.5 inches. Her body mass index is 36, which would classify her as obesity. And her blood pressure is moderate, heart rate is within normal range. So this patient we sent out to get some labs, and she's setting up a telehealth visit with us to discuss what her labs were. I'm sure you've seen this type of patient in your clinic, whether you saw this patient in person or virtually. So we have her recent labs, we have her vital signs here. And you can see that from the last 2 years, her cholesterol levels have been elevated. And the newest finding is that her glucose, her A1C is 5.9. So that places her in the range of impaired fasting glucose or pre-diabetes. And this is a new finding that the patient wants to discuss today. So just looking at this patient so far, Bob, anything that stands out to you, and how would you go forward the conversation? It's a patient with obesity, some elevated cholesterol, newly diagnosed elevated A1C. How would you start this conversation with her?
Well, first of all, it harkens back to this combined epidemic of diabetes and excess body fat. Although she doesn't have diabetes yet, it starts with pre-diabetes. So she's on that trajectory. So that's the first thing that jumps out at me. And I'm already thinking, how can I bring up the topic of her weight now that she has a potential complication of that, and to make the point to her that focusing in on her weight will be extremely important. We call kind of a weight-centric versus glucose-centric approach.
And as an endocrinologist, Scott, this patient is fearful of having type 2 diabetes and the sequelae of such. Have you seen a patient like this who is at risk for diabetes, both because of her family history and her own impending glucose issues?
Well, these are the types of patients that we see every day. And this is a great opportunity for prevention and for not allowing things to progress. And so the way I like to approach this is that this is treatable, and that these problems that you have, we can prevent them from getting worse. And we have tools to do this. And then we sit down and talk about different options and different ways that we can approach obesity.
I like that approach, being proactive and not waiting until a serious diagnosis comes to the table to start with a lot of referrals and piling on medications, really assessing the patient's risk and moving forward.
Honestly, I feel so overwhelmed. I don't want to end up like my mom. She has type 2 diabetes and she's had a lot of complications with it. I just don't want that to happen to me.
So one thing patients really tell us, and this patient says she felt overwhelmed. She doesn't know what to do, but she's really concerned about developing diabetes. Many times they've been victims of bias in their own homes, in their school or work settings, and especially in the medical setting. And some patients may avoid doctors, may avoid medical preventive appointments because they've been embarrassed because of weight bias that they've experienced. And I really feel that as providers treating weight, and anyone out there is treating weight, independent if you're an obesity specialist or family practitioner, we're all seeing patients with obesity. So it's important to know the terms that patients prefer so that they will come back to us, feel comfortable with us, and we can have these integral conversations with them. And it's important that we think of the patient first and use the language first. So it's better to say a person with obesity rather than saying an obese person. Using this type of language in our writing, in our medical records, in our speech, can really help us serve the patient and make them feel comfortable having it. You can see some of the most motivating and least motivating terms by patients who have been surveyed. And I really implore our listeners out there to use these terms when having conversations with the patient. And you can even ask the patient, what would you like me to use as a term when we're discussing your weight?
Holly, if I can, I really want to drive that home. I'm so glad you brought that up, the people first language. We would never say, I have a cancerous patient or an autistic patient. We really move beyond labeling people like that. And yet we still say, I got this obese patient. So just really think about this labeling idea, and the cancerous patient one that really jumps out at me. You would never say such a thing. But using that same thought process is so important and respectful to the patient.
Very much so. And again, we can't forget that our patients have been victims of bias in so many settings, and having these conversations is not easy. And the patients, by the time they're in their office, it's not likely the first time they've tried to lose weight. The average person makes about 8 serious attempts at weight loss in their life, and they're frustrated. They feel embarrassed, overwhelmed. So again, the way we structure a question or a statement to the patient can make all the difference. Rather than telling patients, if you don't lose weight, you will get diabetes, you can say obesity can affect your health in the following ways and list those that are relevant to the patient. You can't say something like, you should just really try to push away from the table, because this is much more than a calories in, calories out behavioral change model. So asking the patient permission to discuss it, what terms they would like to use, using the person first language, and really being empathetic is important, not only for the provider that's treating the patient, but anyone who makes contact with them. That's the phone staff, that's our front desk staff, the patient's MA doing the vitals. We really want to make sure that they use this person first language and make them feel comfortable.
Honestly, I feel so overwhelmed. I don't want to end up like my mom. She has type 2 diabetes and she's had a lot of complications with it. I just don't want that to happen to me.
That does sound overwhelming. I hear you. You want to make changes for your health and your future, and I'm here to lend support. Do you mind if we talk about your weight and where you feel you are right now?
Am I going to get diabetes if I don't lose some weight? I'm not happy with my weight, but I just honestly, I don't even know where to start. Ever since I lost weight a few years ago, it's just been so hard to not only lose more weight, but just even maintain the weight loss.
So we have these messages from our patient. As you heard the conversation between the patient and the doctor, I want to ask my colleagues feedback. How do you deal with that in your practice?
Well, I think you make some really good points. And I think the first step is really trying to not have the patient feel overwhelmed or feel blamed. It's not just us as the physicians or as the advanced practitioners, but everyone in the office should be trained about obesity, bias, and stigma, and how to make patients feel comfortable.
Yeah, Holly, let me pick up on that point in this dialogue that she's lost weight and it's hard to keep it off and it comes back. That is probably such an important aspect that healthcare professionals need to have an understanding of the biology of obesity, why that occurs, and then have a script already in their mind about why is that happening. Because the last thing you want to do is talk to a patient about, well, metabolic adaptation, body, BMR goes down, and ghrelin goes up. That doesn't make any sense to patients. But for us as clinicians to understand the biology of appetite dysregulation, metabolic adaptation, change in muscle efficiency, and then convey that in simple terms to the patient. The way I do it very quickly is that over millennia, our bodies have been engineered really to survive starvation and famine. And anytime the body senses a reduction in caloric intake or food intake, even though you're wanting to do that to lose weight, biologically, the body starts to defend itself. And it's harder and harder to lose weight. You have to think our ancestors from hundreds of thousands of years ago, what's going on. But it's not their fault is where this whole conversation lands. It's not that they're doing something wrong. It's the way biology works. And we are going to work with you to do the best you can to maintain your health or to maintain your weight and optimize your health.
That is an excellent point. It's important that as we go through some of these slides later that talk about the hormonal regulation of weight, that we explain this process to patients so they can take some of the blame, the shame and helplessness out of treating weight, and open up to you as a provider so we can help them move forward with a more holistic understanding about obesity and overweight as conditions. We see a weight graph here of an actual patient from my clinic. They did a very low calorie diet on the sharp decline that you see, and over a series of almost a decade regained about half of that weight. And I learned this from you, Bob, as well. I have patients draw a weight graph of their adult weight to where they are right now, and to put some events in there. Maybe there was a diet and exercise program you did and you lost, and maybe there was a job change and you gained, or maybe there was an emotional situation and you lost or gained. So one, I can get a sense of what affects the patient's weight. And when they draw this graph, we often see a pattern that looks like the graph you see here. So I take this time to help them understand that they are not the only one who's dealt with this, that weight maintenance is very difficult, and it happens because of a series of hormonal changes. And again, this is our body's natural adaptation to creating a caloric deficit, which is what we have been telling our patients is the best way to lose weight over time. So I always think of what will make this time different for the patient, and often explaining this metabolic adaptation, the changes in metabolism, the changes in appetite that cause weight regain, and then focus on how we can adjust those to make the environment and the physiology more conducive to long-term weight loss and weight maintenance.
I just want to put a shout out to your graph here. One thing, the electronic medical record has been wonderful, right, for all of us. But one thing it has really helped us with communication is to use the graph tab in electronic medical record. And by showing the kind of data you're talking about now, people love seeing data, right? Every time I turn the screen to a patient, they go, "That's me." They really love that kind of thing. And really going through the life events, as you just mentioned, here I see, a few years ago, you lost 20 pounds. What was going on there? And here you gained half of it back. What was going on there? So it is an underlying idea of metabolic adaptation, but people don't understand that. They think about life events, and that could be a window into potentially further treatment. Like every time they get depressed or anxious, or someone's visiting their home and it distracts them and all that kind of stuff. It helps you problem solve for the future of what may trigger weight regain and potentially treat it.
Those life events really represent environmental change, and that's something that we'll talk about because we only have control over some of the determinants of our metabolism. So patients come to me and they say, "I wish I could just boost my metabolism. I know everything will be better. It seems that as time has gone on, my metabolism has just dulled to nothing, and I'm really unable to lose weight." So I think it's important to explain to patients what metabolism is, what can bring it up, what can bring it down. So we have a graphic here that explains what metabolism is, and that's total energy expenditure, or basically how much energy it takes to run a person at a given time for a day. So on the left here, you have your resting metabolic rate, which is basically how much energy it takes for you to survive if you just wake up and don't move one day. And that differs for every patient, even if they're the same height and same weight. It has to do with your fat mass, it has to do with your muscle mass, your water percentage, and also it can vary in one person's life. So this is a number that is in flux. It's not staying the same from 18 to death. It does change. Then we have the thermic effect of food. So this is how much energy it takes to digest and metabolize the food that you've eaten for that day. And then, of course, our total energy expenditure has to do with how much energy we are using, from doing mundane things like walking around to purposeful physical activity to fidgeting even. So these make up our total energy expenditure, which is known as our metabolism. Now on the right, you see different factors that contribute to one's total energy expenditure. But in the blue boxes are the ones that we have control over. We're not able to control our genes or our age, but we can control some environmental stimuli, such as our diet, exercise, and behaviors. We can adjust our physical activity. And then there are other factors which we may not even be aware are present, such as insulin resistance, which can make us form stable fat cells. We have to put in there medications, which can make us store more fat cells. So if you've tried 8 times in your life and the 9th time you're doing a program, you get no result, it's because the body is getting smarter and saying, "This famine, you're eating less and moving more, I am no longer going to respond to it because I want you to survive this famine." And that's what our bodies have adapted to, and which makes it so hard to lose weight in our current environment where food is plentiful. So I explain this to patients to say, these are the factors you have control over, but there are many factors we can't control. So we can try to adjust physiology while we work on the lifestyle benefit to get the best results.
Yeah, sure. So I work on film sets. I put up together all the different props and everything like that. It can be pretty physically demanding. I do work up a sweat as I'm setting it up, but once I'm done with that and the set is set up, I will sit down for most of the day. So as far as food goes, the studio usually provides us with meals, but they aren't really super healthy. Oh, and I also like to take walks with my boyfriend on the weekends. They typically will be about 45 minutes, maybe an hour long, depends on the weather. Um, but honestly, just thinking about finding time to exercise more just seems really overwhelming.
So I wanted to ask you, Bob, how do you start to set a goal with a patient who's overwhelmed, has a new diagnosis of a precondition, and has some concern about developing a weight-related medical condition?
Yeah, overwhelmed needs to be underlined many times, right? My biggest fear is when someone comes to see me, the last thing I want to do is to have them walk out of my office overwhelmed. And how you know they're not overwhelmed is by verbal and nonverbal cues. Tell me what we're going to do and so on. But when it comes to goal setting, it's really important to think about the phrase SMART goals, right? So specific, measurable, achievable, relevant, time bound. So that is critical. So a way of not having someone be overwhelmed is to take a particular single goal. Let's say I'm going to start having a regular meal pattern or eat breakfast. And then you really take them through it. Is when are you going to have it? Where are you going to have it? Did you purchase food? Is it in the refrigerator? You can do the same thing on the weekends. Why is it important? By using SMART goals, you can then go from one to the other. Some of us want to do no more than one in fear of overwhelming people, but there's a whole body of literature now using multiple behavior change at the same time. And I actually find that healthy behaviors often cluster together. For example, someone who's running marathons rarely is going to get in the car and smoke. They're going to eat healthy and be a runner. So you often have an opportunity to pair healthy things together. But again, the whole idea of not overwhelming them.
Absolutely. It's important to gauge the patient's ability as an individual to have one or more goals. So this is the concept of shared decision making. With each SMART goal that's started, it's important to write it down. Ask the patient, do they agree? Scott, have you had experience with using this shared decision making type of module in your patients' visits? And how's your relationship with your patients been in using this type of module?
Well, I like using shared decision making. I think it's also an education process for the patients because you do get a lot of patients that just say, well, just tell me what to do, especially when it comes to deciding on a medication. I use the term shared decision making because I want them to be involved. I want them to be part of the process. And they never do as well if you just dictate and tell them what to do. And so we really try to get them on board, trying to come up with some of their own ideas about what they can do as having a SMART goal, something that they can do to improve their health, to improve their diet. The last thing that I want to do is tell someone, just eat less and exercise more, because it's so frustrating for patients and it just doesn't work when you tell them that.
That's really excellent advice. And then listening and having a conversation with the patient. I can't stress enough how patients feel overwhelmed already with their diagnoses and the idea that they have to lose weight again. And they feel that they have to make drastic changes. Listen to the patient and know what their reasons for losing weight are, and try to pair those with the SMART goals that you've made at each visit and build upon them rather than presenting them 15 SMART goals at once and the patient coming back and saying, I only did one and I don't want you to be disappointed in me. The fact is, we're trying to make change and get progress. The goal is never perfection. So I stress that to the patients. I'd like to see you back whether your weight goes up, down, or stays the same, so that we can continue to make new plans for you, because your environment will change and thus your plan will change as we have a relationship moving toward weight management. So again, the specifics of those SMART goals are so important, and making sure that the patients are aware that we will continue to help them out whether we're getting weight loss or if they're not getting that at all, because it's going to be an ongoing process for a long time. Even when they achieve goal weight, we focus on maintenance.
Holly, let me ask you a question, which has to do with M, which is measurable. It's been kind of a hallmark that we ask patients to track their diet, right? That's you measure, calories, for example. Is that something you routinely do? Do you have people track their diet when you want them to change their diet?
I actually do not mention calories at all when I initially see a patient. This can be very triggering for some patients, and they've done this exercise, and it's a very concerning when a patient says, I ate this very few calories and I didn't even get a weight loss result, and I'm hungry, and now I feel like I need to eat less and less and less. And it also can breed the idea that you need to have a very restrictive diet and even take yourself out of social situations in order to get success. I think measurable means not just tracking calories and portions. I actually have patients look at their hand size and base their portions on that rather than teaspoons and ounces, but really toward getting success. So if we are doing as best we can with diet, exercise, and behaviors, right now I don't have any gene strategies. If we're not getting effective weight loss or weight maintenance with adjusting the environmental stimuli, then we can look to medications to adjust the physiology of the body to make it more conducive to weight loss. And then I ask the patient, is this something that you would like to address so that we can get you more results?
We've learned that the lifestyle is still always the cornerstone of weight management, but there are times when no matter how hard someone's trying, they're not completely successful. And so now we have anti-obesity medications that can help provide that support to the lifestyle to help lower calories and help sustain weight loss. And so this slide is showing some of the first generation anti-obesity medications that we have as tools to help our patients. And the first one listed is phentermine. It's a medication that's been around for a long time, but we still use it. And it's effective at reducing appetite. And although it's approved for short-term use, there is data looking at phentermine for long-term use. And so because obesity is a chronic disease, this can be used at lower doses chronically. Orlistat is the only medication on this list that doesn't work by reducing appetite. It's a gastrointestinal lipase inhibitor, and it works for chronic obesity management by reducing the absorption of fat in the diet. The next medication combines phentermine and topiramate ER, and so the two medications synergize with different mechanisms of action to help with weight loss. And so we can use lower doses, and this medication also works to reduce appetite. The next one is naltrexone bupropion ER, and this is another combination drug. And so again, these two medications synergize. It actually works in two different parts of the brain to reduce appetite and also reduce cravings, and that's the way that it assists with weight loss. And then the final first generation anti-obesity medication that I want to discuss is liraglutide, which is an injectable GLP-1 receptor agonist. It's given every day. This medication is also used in the treatment of diabetes, but here we're discussing it as a treatment of chronic obesity. And this medication works also by reducing appetite. So the first generation medications, they can also have the risks that we want to be aware of. And with phentermine, we don't want to use in patients with history of cardiovascular disease because of the risk of pulmonary hypertension or other serious cardiac events. So it would be contraindicated in a patient like that. Orlistat, the one that I see the most is steatorrhea because it can create a malabsorption of fat. And so there can be oily spotting of the undergarments or flatus with discharge, fecal urgency, or a fatty, oily stool. Some patients do struggle with compliance with this medication, but really by encouraging a low-fat diet, a diet that contains less than 30% of fat, we can manage the side effects of orlistat. Phentermine and topiramate, the serious side effects can be suicidal ideation or acute angle glaucoma, sleep disorders, cognitive impairment. Some patients do complain of that sort of mental impairment or brain fog when they take this medication, but that does tend to improve with time. Naltrexone, bupropion, the most common side effect by far is nausea. And this is a dose-dependent side effect, and it's also a time-dependent side effect. So we start the medication at a low dose, and it's titrated up slowly. And the serious side effects can be seizure or suicidal ideations or acute angle glaucoma. Liraglutide, the most common side effect is nausea. And again, nausea is dose-dependent and also time-dependent and tends to get better with time. The other side effects tend to be all gastrointestinal in nature, diarrhea or constipation, upset stomach. The serious side effects to consider would be acute pancreatitis and acute gallbladder disease. I just want to highlight this slide comparing the U.S. population prevalence of diabetes and the increases over the years with percentage of patients with diabetes who have obesity or have a body mass index greater than 30. And so we can see that when patients have obesity, they very frequently coexist with diabetes. In fact, 60 to 80% of people with diabetes have a body mass index greater than 30. So when we can have a medication that treats both diabetes and obesity, it seems like it would be the ideal way of treating these types of patients. And so this slide is from the algorithm from the 2023 Standards of Care in Diabetes from the American Diabetes Association, showing the pharmacologic approaches to the glycemic treatment of diabetes and the use of glucose-lowering medications. On the right, we have the considerations for patients who have obesity and diabetes and medications that should be chosen or should be preferred if someone has obesity. And the idea is that you want to set individualized weight management goals. And after we've emphasized lifestyle, medical nutrition therapy, and physical activity, then we can consider medications that have efficacy for weight loss. And we want to prioritize those that have very high efficacy, which would be semaglutide and tirzepatide. But we can also use medications that have high efficacy, which are dulaglutide and liraglutide. And then other medications that have efficacy in weight loss can be the other GLP-1 receptor agonists or the SGLT2 receptor inhibitors. And then there's also the weight neutral medications. But the point is that we want to try to give a medication to our patients that's going to help with both glycemic control and weight control. And so when we talk about the second generation anti-obesity medications, there are really two that we have on the list, semaglutide and tirzepatide. And the definition of a second generation anti-obesity medication is one that has the ability to safely produce, on average, at least 10% weight loss subtracted from the placebo in a randomized clinical trial, or about 15% of weight loss in half the patients who take the medication, of course, when combined with lifestyle. And so now we've added in the second generation anti-obesity medications to this table, and we see that both semaglutide and tirzepatide are listed. Although semaglutide is approved for chronic obesity management, tirzepatide is for chronic type 2 diabetes treatment with weight loss. Now, comparing the difference between the two, semaglutide is a GLP-1 receptor agonist, similar to liraglutide, but with a longer half-life. And so the injection can be given once a week instead of daily. And we do see more significant weight loss with semaglutide, typically greater than 10%. And tirzepatide, also a weekly injection, is a dual receptor agonist at both GLP-1 and GIP. And the combination is effective for decreasing appetite and also giving second generation numbers greater than 10%, typically greater than 15% with weight loss. So I just want to ask Dr. Kushner, how would you approach the use of these newer second generation medications?
I want to underscore for everyone, I think how significant this change has been, this development of second generation medications, of which this is the first of a wave of new medications coming out, really represents a paradigm shift in the treatment of obesity. And I think the sooner that clinicians familiarize yourself with these medications and become comfortable using them, they're going to stay ahead of the curve with the treatment of obesity. For the first time, we are shifting our treatment of obesity to a hormonally based disease. It's similar to giving insulin to someone with diabetes, right? They already make insulin, but by giving back insulin at higher doses, we're getting a greater effect on glucose control. Same thing here by giving mimics of gut hormones, GLP-1, GIP, amylin, others to come. We are augmenting and treating the appetite dysregulation that people have with obesity. So that's the first thing I want to say, is that clinicians need to be aware that this is a shift, and it's going to get more and more exciting as time goes on. The second generation medications is really shifting to getting to the underlying appetite dysregulation that many of these patients have with obesity.
I think you made a lot of really good points. And the one that I just wanted to emphasize was that these medications basically are treating the underlying defect that we see with metabolic adaptation, at least one of them, with GLP-1 being low. And so we're replacing the missing hormone. And so it really has a biological basis for the treatment of obesity. And emphasizing the second generation approach is the amount of weight loss, because just coming back to the slide that was shown earlier, there is a dose-dependent effect of weight loss on medical complications. And so essentially more is better for a lot of conditions, and especially conditions like non-alcoholic fatty liver disease, obstructive sleep apnea, and GERD. You really need to get at least 10% weight loss to really see a significant effect on these medical comorbidities. And so to be able to have a second generation drug that can produce the amount of weight loss that's necessary to impact these diseases is very helpful. And so I just want to discuss briefly tirzepatide, which is a new GIP and GLP-1 receptor agonist. It's been modified to bind both GIP and the GLP-1 receptors. And this medication enhances first and second phase insulin secretion. It reduces glucagon levels, and both of this is in a glucose-dependent manner. So we call it like a smart drug, that when it's affecting glucose, it's mostly working when the glucose levels are high. And that's also why we don't see a lot of hypoglycemia with this medication.
Scott, if I may, this is all really exciting, of course, to us as obesity providers and to primary care physicians out there, and of course to our patients. And I heard you and Bob use some interesting terms: new, novel, second generation, paradigm shifts. And some of my patients have expressed concern that, is this too new? Do we know enough about it to know its safety and efficacy in patients long term? And I don't want the audience to be put off by how recent the references are in the slides that we have here. We see 2023, which is when we are presenting this data, because these medications have been used in patients with type 2 diabetes, not only clinically for years, but also in the trials to prove their safety and efficacy in patients with type 2 diabetes. And it was such an impressive response in patients with type 2 diabetes. And then they had improved clinical responses when it was put on a population level, that the decision was made to then study these for years. So some of the trials that we looked at, semaglutide, tirzepatide, they're 2 to 5 years long. And then we're now looking at it to see if there's any difference in the physiology of a patient without type 2 diabetes. And again, I want you to know this has to be proven to be safe and effective in this population before the drug can get on the market for the indication of weight management.
I think that's an excellent point, and that's a lot of what we hear from our patients. And the question is always about long-term side effects and what can they expect. They're just getting better. The half-lives are getting longer, so they can be taken less frequently, and the effects are better than the earlier versions of these medications. But we do have experience with this class of drugs for quite some time.